Great. Thank you, Sherry, and thank you, panel. That was incredibly interesting. And you guys were only like 5 minutes behind schedule. So it's pretty impressive with everything that we've covered. And I do want to just, it's a slight plug for my session coming in the future on day 3. But I do think, the question about PPH at cesarean section is a critical issue. Talking about early recognition, management of that, and just how the increase in cesarean section rates all kind of add to that challenge. So if you're interested, please join me on day 3 in my breakout session. So now we're going to go on to the next session, and this was a great session for setting the stage around the epidemiology, looking at what's important about the having accurate data, talking about some of the bundles that we're talking about is really kind of sets the stage for this next session, which is looking at the emerging evidence and critical gaps areas in for PPH. So for the first session, we're going to recall Mariana. Mariana Widmer is the technical officer at the Sexual Reproductive Health Department of WHO. She is a biochemist by training with a master's degree on science and bioethics, with almost 18 years experience in the area of maternal health research. And she'll be talking to us about the updated WHO PPH recommendations. Mariana.
Thanks, John. You didn't let me stretch. I didn't have time to stretch. All right. So thanks again for the introduction. And now I will present the updated WHO recommendations related to PPH. Next, please. So WHO published the first recommendations on prevention and treatment of PPH in 2012. Since then, a lot has happened in the area of PPH, and several of those recommendations had to be updated. However, the process of updating a recommendation is quite complex and takes time. So at the end of year 2016, WHO adopted what we call the living guideline approach, and is what actually Mercedes presented at the very beginning today. So that consists in dynamic system of updating WHO recommendations as soon as a relevant new evidence becomes available. So under this approach, a recommendation will be updated if the question is of public health importance and could change clinical practice globally, if there is new evidence that has the potential to impact the existing WHO recommendations. So a good example is what happened in 2017 when we updated the recommendations on tranexamic acid for PPH treatment. And this was in response to the new evidence mainly coming from the WOMAN trial. In 2018, again, in light of the new evidence mainly coming from the CHAMPION trial, we updated the recommendations on uterotonics for PPH prevention. And finally, this year, we updated a set of 4 PPH recommendations. These are related to the UVT use, oxytocin umbilical vein injection for retained placenta, routes of oxytocin for PPH prevention, and advanced misoprostol distribution for the prevention of PPH. Next, please. So let's look at the recommendations on tranexamic acid. The recommendation reads, early use of intravenous tranexamic acid within 3 hours of birth is, in addition to standard care, is recommended for women with clinically diagnosed postpartum hemorrhage following vaginal delivery or cesarean section. So the tranexamic administration should be considered as part of the standard PPH treatment package. It should be given as soon as possible after birth to achieve clinical benefits. The administration beyond 3 hours does not confer clinical benefits, we know that. And if bleeding continues after 30 minutes, or if bleeding restarts within 24 hours of completing the first dose, a second dose of tranexamic acid is possible. Next, please. So, in 2018, as I said, we updated the recommendations on uterotonics for PPH prevention. So, we recommend to use an effective uterotonic for the prevention of PPH in all births. Oxytocin is the first choice. If oxytocin is not available or its quality cannot be guaranteed, the use of other injectable uterotonics, including heat-stable carbetocin, is recommended. And in those settings where there is no skilled health personnel available, a community health worker can administer misoprostol. Please remember that here I'm talking about PPH prevention only. Next, please. So this is the flow chart that we developed to explain how to implement the uterotonic recommendations, because I summarized very, very quickly, but the guideline is quite extensive. So very briefly, the first question that you have to make is if there is a skilled health personnel who can administer injectable uterotonics, if that skilled health personnel is available. If there is, and you have oxytocin of good quality, you use oxytocin. So the recommendation is to use oxytocin. If the oxytocin is not good quality, or you can either use heat-stable carbetocin if the cost in your setting is comparable to other effective uterotonics, or you can use ergometrin or fixed dose oxy-ergo if the woman does not have hypertension, or you can use misoprostol. Now, if in your setting you don't have a skilled health personnel, then we recommend to use misoprostol. Next, please. So let's look now at the new set of PPH recommendations just updated. And as you see, I didn't put a cover because these recommendations were approved, but still they were not published. So we are under a type of embargo. So, but I will try to mention the recommendations so you are all aware of what is new. So regarding the routes of oxytocin for the prevention of PPH, we say that we recommend the use of oxytocin, 10 international units IM or IV, for the prevention of PPH for all births. And in situations where women already have an IV line, the slow IV administration of 10 international units of oxytocin is recommended in preference to IM administration. Regarding the antenatal distribution of misoprostol to pregnant women for the prevention of PPH, we recommend this strategy in settings where women give birth outside the health facility and in absence of a skilled health personnel, but only with targeted monitoring and evaluation. So this is what we call a context-specific recommendation. And this is because we don't want to replace standard policies for scaling up effective uterotonic use, but rather increasing the coverage of uterotonic use, where it is highly likely that skilled health personnel will not be present at time of birth. Let's look now at the umbilical vein injection. So it is recommended for the treatment of retained placenta only in the context of rigorous research, because the effect of this intervention on other priority outcomes, including infections, maternal satisfaction, and length of hospitalization, is unclear. So when compared with injection of other solutions and uterotonics, no other umbilical vein injection regimen was shown to be clearly better than that with oxytocin. So this is the reason why we recommend it, and it's a context recommendation. Finally, the recommendation on UBT, uterine balloon tamponade. We say that uterine balloon tamponade is recommended for the treatment of PPH due to uterine atony after vaginal birth in women who do not respond to standard first-line treatment, provided that there is immediate recourse to surgical interventions if needed. A PPH first-line treatment protocol is available and routinely implemented. Other causes of PPH, such as retained placenta or trauma, can be reasonably excluded. The procedure is performed by a health personnel who are trained and skilled in the management of PPH, including the use of uterine balloon tamponade, and maternal condition can be regularly and adequately monitored for prompt identification of any signs of deterioration. Again, this is a context-specific recommendation. So I'm sorry I cannot show you the wording of all the recommendations, but I thought it was interesting for you just to listen to them and to have your reactions. So, all right, so these are all the updates that we have in the area of PPH. We are continuing working and looking at new research questions. So we have a group looking after all our priority areas. And for this year, these are the 4 that we updated. So thank you very much for your attention. I'm happy to answer questions.
Thank you, Mariana. That's great, and sorry for not giving you enough time to stretch in between. We're called upon you quite heavily today. And this is great, and so we're going to hold the questions until after the next 2 presentations, but continue to put them into the question and answer. And this was really useful. I think a lot of people wonder about the WHO process, so kind of shining a light on that a little bit is helpful, and I'm sure there's further questions about that. And also just highlighting the update on TXA. I know it's been out for a couple of years, but still just disseminating that information is important. And also the issue about the different types of uterotonics. And I know we keep mentioning about heat stable carpitocin. We do have an interesting session tomorrow around the modeling of that. So if you're interested in learning a little bit more about kind of the cost modeling around that, then certainly join that. Great, so now I'm going to turn to the session where we'll start talking about the evidence, the recent evidence around UBT. And first, I'm going to turn to Fernando Altavi, who's a medical officer of the Human Reproduction Program at the Department of Sexual and Reproductive Health and Research at WHO. He's an obstetrician gynecologist by training, an epidemiologist and trialist on maternal and perinatal health research. Fernando, you're welcome.
Thanks so much, John. Thanks to everyone. I'm very, very glad to be here and just to participate, very interested in saying the next in this day and the next couple of days. Actually very interesting discussions and information. I will just try to very, very briefly, I will take only 5 minutes, just to continue on what Mariana has very well summarized. And again, so sorry that because we cannot, let's say, show right now how the, let's say, the updated recommendations will look like. However, conceptually, I think that it was clear, and I will try to repeat this and provide a little bit more information. Actually, next, please. What Mariana well summarized is that the UBT updated recommendation right now will look like that UBT is recommended in specific settings. And for the treatment of refractory PPH after vaginal birth and caused by uterine atomy, or presumably by uterine atomy. And the kind of preconditions for that setting is that have a kind of a immediate access to surgical interventions, have a good quality PPH care available, protocols, products, and also, let's say, good training on UBT's, let's say, use and the possibility also to exclude other causes of PPH. This evidence, sorry, this recommendations actually was discussed during a March meeting, kind of a mixed virtual and just starting, let's say, with the COVID lockdown. In Geneva, half of the people there, half of the people outside. A GDG group, a guideline development group composed by 14 people, plus several observers working, let's say, for 2 days and reviewing the evidence, mainly coming from effectiveness, let's say, systematic reviews, one Cochrane review, especially updated for the, let's say, for to inform, let's say, this recommendation. One very comprehensive review also published early this year by Suarez, and also a WHO, let's say, systematic review that is about to be published probably soon. So based on all that, plus other, let's say, cost effectiveness reviews, also especially designed for this, let's say, update process, and a few qualitative reviews regarding, let's say, the preferences and views from the providers and women. And finally, assessing all these in several dimensions, coming from, let's say, the desirable effects and undesirable effects, the balance, cost effectiveness, feasibility, acceptability, equity. Let's say we came finally up with these recommendations, summarizing that in a way, the evidence is not good right now in the level of the certainty that the evidence, let's say, supporting, let's say, that UBT in any setting could be, let's say, recommendable. But there was a consensus among the JDG that the evidence, although, let's say, it's not good quality, actually supports the use of UBT in settings in which, let's say, these preconditions can be met. And that, but the evidence is not good quality right now, and we need better research in settings in which these, let's say, conditions cannot be met in particular. And we acknowledge that, let's say, the operationalization of these preconditions is not an easy task. So that's also part of the next slide, in which we discussed also intensively what are the research gaps and what are, in some view, for this group, for this JDG group, what are the research priorities around UBT. So, and we may say that in settings not meeting these preconditions, that could be, let's say, very primary healthcare settings, definitely we need better research to test the effectiveness and safety of mainly purpose-designed UBT devices. That will be the first priority in, let's say, on behalf of this let's say, group of reviewers. At the same time, let's say, definitely one important question is whether also UBT as a temporizing measure, let's say, in preparation for the treatment of refractory PPH in women that will be referred to a higher level of care. That's a crucial, let's say, question. And as I mentioned before, let's say, these essential preconditions that the health service should meet right now just to be, in a way, categorized or defined as complying with, let's say, the preconditions necessary for use of the UBT, let's say, based on the current, let's say, information we have about its effectiveness and safety. It's also, let's say, crucial to understand. And next one, please. However, in those settings in which that actually meet some of these preconditions, again, let's say, have a kind of a readily access to surgical interventions, reasonable, let's say, PPH quality of care regarding supplies and training and processes, and also a good training regarding the use of UBT with some competence levels. Let's say different type of UBT devices, let's say, improvised devices, low-cost purpose devices should be tested in, let's say, in these settings, because it's probably in the settings in which the women right now are will be safer. At the same time, we need to test new devices and to compare the balloon devices actually with new design devices using a different mechanism of action, which are the suction devices, using vacuum forces just to collapse uterus. Clearly, there is a, let's say, there has been, let's say, several publications regarding the use of tamponade devices for PPH at cesarean section. That's also a crucial, say, area of research. Right now, there is no good evidence just to probably to consensuate a recommendation. And finally, the training modalities for assuring the competency in the use of UBT, again, is definitely, let's say, an important issue to deal with. as in some way this has been acknowledged, but as let's say coming from the previous evidence used for this recommendation as one of the let's say aspects that should be better researched. So I will be very, very glad to answer questions in the short time that we have, and thanks so much. John, over to you.
Great, thanks, Fernando. For the sake of time, I'm going to, since this is still on the line of UBT, I want to move to the next presentation, and I'm going to welcome Jill DeRocher, who's a director at Genuity Health Projects. She has spent the past several years coordinating a large portfolio of research on the use of misoprostol and other low-tech interventions that have the potential to improve management options for PPH and LMICs. Jill, you're welcome.
Thank you. Thanks for the introduction and the opportunity to participate in this meeting and among this panelists. Today, this presentation, I will try to move quickly, so there's plenty of time for question and answer. So to fill some of these research gaps around the use of UBT, today I'll be sharing some findings on the safety and acceptability of UBT, specifically looking at postpartum infection and pain levels that women report experiencing during their PPH care. I just want to thank our team of investigators. It's a large team, including the Massachusetts General Hospital, country investigators in Egypt, Uganda, and Senegal. And also just to mention that the findings I'm presenting today are not published, so please refrain from citing them and sharing outside of this conference today. Next slide, please. So this was work evaluating the condom catheter UBT for PPH treatment, and the images on the right-hand side will show the supplies that were used. They're locally available materials. This is again based on a model that was implemented by the Massachusetts General Hospital with their input. And the purpose was to use locally sourced materials to create kits that were available and ready to use at the hospitals for treatment of refractory hemorrhage. The study was conducted in 3 countries that were just mentioned, Egypt, Senegal, and Uganda, in 18 secondary or district level hospitals. And this study population focused on vaginal births, and again, focusing on PPH diagnosis that was suspected to be due to uterine atony, and refractory hemorrhage. This is a refractory hemorrhage after uterotonics and other measures had been used, and if the bleeding continued, the UBT was then indicated. Just to mention that the context that we're working in is very similar to the preconditions that were just mentioned by Mariana and Fernando in their presentations. So again, just to mention, this was a cohort study. We were comparing infection rates and pain levels reported by women among 2 cohorts, women who received a UBT and women who had PPH and were treated but did not receive a UBT. And our key outcomes were reported pain levels, which was measured on a 10-point scale. And then we also asked women 4 weeks postpartum about their use of antibiotics as a proxy measure for infection, along with some other questions that were asked about infection to get a sense of the infection rate among these populations. Next slide, please. So this work is part of a large study that was conducted and published over a year, or about a year ago. And today I will be focusing on the safety and satisfaction of care outcomes and not the effectiveness outcomes that were reported in this publication. Just to mention, could you actually click on the slide? There's a part that's missing. Thank you. So today's presentation will focus on, as I just said, these outcomes of infection and pain. So over nearly 2,400 women were diagnosed with postpartum hemorrhage. And among these, we have over 2,000 women who were treated without a UBT. So they were treated with uterotonics and standard of care, and the UBT was not indicated. And in the UBT cohort, there were 64 women treated with UBT. Women who then consented to be interviewed were slightly less, and then there were also some women who did perish in both cohorts. So our sample is reduced, as you will see down the cohort group. In the end, we had 57 women in the UBT cohort who were followed up at 4 weeks, and over 2,100 in the no UBT group who were followed up at 4 weeks to ask a series of questions about infection. Next slide, please. So before I share the main results, I just wanted to highlight some of the background characteristics among these two cohorts. We were interested in looking at PPH interventions, other PPH interventions that might increase risk for infection or pain levels. So here we can see that there were no differences in the rates of PPH of manual exploration, suturing, bimanual compression between the two cohorts. However, you will see that there was a higher rate of invasive surgery conducted among the UBT group, which was a 7% rate compared to 1% in the no UBT group. For pain management, just to say that in this setting, here I am showing women who received any pain management, which was quite low, 30% in the no UBT cohort and 41% in the UBT group without any statistical difference. And just to mention, we are accounting for clustering by study facility in these analyses. But just to say that the majority of the pain management practices were just analgesic medicines given. There was a very low frequency of anesthesia used in this population. So not a whole lot of management for pain during childbirth and during the course of the management of the PPH. With regard to antibiotic use, I just want to highlight that women during the training, women were given, well, the study staff was trained and asked to administer a broad spectrum antibiotic to any woman who was given an UBT. So we can see that immediately postpartum, the antibiotic use was 90% in the UBT cohort compared to 48% in the no UBT group. However, if you look at antibiotic use in labor and delivery, and also women who were discharged on oral antibiotics, you can just see that antibiotic use was overall very high among this population of women across both of these cohorts. Next slide, please. So to get to the outcomes on the pain levels, so women prior to discharge, after their postpartum hemorrhage was controlled and they were ready for hospital discharge, those who consented were asked questions about their pain levels after delivery. So on the left-hand side, we see the chart showing among the two groups their pain levels on the scale from 0 to 10. And you can see notably that women in the UBT group more frequently reported a high level of pain of 8 to 10, 37% compared to 20% in the no UBT group. And that was a statistically significant finding. When we control for other interventions and pain management practices, as well as those PPH other treatments that were used, this finding remains statistically significant. However, when we control for country, it does lose statistical significance in that finding. However, it's still very notable, this pattern. At 4 weeks postpartum, women were contacted and interviewed by the study staff about and asked a series of questions about their antibiotic use. Were they diagnosed with an infection? Did they seek care after their discharge for any problems? And what were those problems? A series of questions to get a sense of infection, the possibility of infection among these two cohorts. So to highlight its self-reported outcomes by women reporting on this. And we can see that there were no differences between the two cohorts in those who were reported receiving antibiotics. And then also we see a 2% report of diagnosis of infection among the no UBT group compared to 0 in the UBT group. But also just to mention and remind everyone that the UBT group is quite small. So it's possible that we were, and it is indeed true that we didn't have may not have a large enough sample to measure infection, along with the other caveats of self-reported outcomes. Nevertheless, I do think these findings still provide important information for looking at pain levels and infection following use of a condom catheter UBT in these lower middle income country hospital settings. Next slide, please. So another aspect of our study was to ask about their acceptability and satisfaction with their PPH care. And I'm just presenting one slide on this today, although we collected a lot more data on their quality of care and women's impressions of their PPH care. So women were asked what they liked most about their care, and we have a sample of over 2,000 women. And women were very keen to respond to this question and say, you know, the good quality service at 44%. 12% also said this care saved her life. When we asked about the aspects of care that they least liked, there was a substantial proportion that did not reply, which may be that there were no aspects that they liked the least, but also there may have been some reluctance to comment on this question because the interviewers were hospital staff at the place where they received care. So we should keep that in mind when we're considering this information. So I think what's most important to highlight is that these are women who are being treated for a life-threatening complication after birth. And 33% of these 1,500 women mentioned that the medicines were unavailable or supplies were unavailable. And when we look at this relates a lot to uterotonics. This relates to supplies needed to administer uterotonics. And often those supplies were not available, or they were asked, or a family member was asked to go purchase them at a nearby pharmacy to bring in. And this is not reported in this slide, but actually I believe there was another 5% who commented on the lack of blood being available for their PPH care. And another point to highlight is that the 5% on the far right side who commented on staff being rude or abusive, and which is just an unacceptable and disappointing thing to hear. We are aware that this happens, and I know there's a lot of effort to understand this and address this issue. But again, we need to really keep that point in mind when we're thinking about quality of care for women. Next slide. So in sum, we really, in this analysis, we did not see any evidence of infection with this condom catheter balloon among this group of women. I really think we need to keep in mind the high use of prophylactic antibiotics that were used, and also the caveats with respect to recall bias and the small sample. But again, we didn't see any evidence of concern for infection rates being higher among women who received UBT compared to those who did not. The pain management among the UBT cohort, given the higher pain levels reported among the women, suggests that the pain management may not have been adequate. And I think this is an important area for future research and an important issue for addressing the quality of care. And then again, you know, when we're introducing new technologies like UBT, women's satisfaction with their care and stockouts of basic supplies deserve our full attention. We can't make significant changes in improving care without the basics. And we heard earlier today in the first presentation about the concerns around supplies with COVID-19, and I think these issues were happening before COVID-19 and have the potential to become worse for women. So I really would like to emphasize that point. So next slide, please. And thanks to all. Thank you for your attention today. I hope there's time for questions. And this was an incredible study, an incredible amount of work, and I'm really happy to be able to share it with all of you today. Thanks.
Thanks, Jill and Fernando, for your presentations on UBT. And we do have time for questions. We'll definitely get to that. We may be a little bit short, but just reflecting on those two presentations, I think what's, at least to me, what was the thing that was kind of interesting was on the one side where Fernando talking about one of the things I would like to hear a little bit more about is kind of the preconditions for UBT and having access to surgical interventions. But then that tying to the acknowledged research gaps as UBT as a temporizing measure, I think is important and worth further discussion. And Jill, we talk often about effectiveness, but I like the idea that how you brought in around patient safety, acceptability, and satisfaction. So I think that those are important. So we're going to turn to questions now. We'll take a few, maybe 2 to 3. And as I said, if we don't get through all these questions, and we won't, we'll make sure that we answer these in written manner. So I'm going to start with a question from Lipine Mercier, who question was about TXA. So this is for the guidelines. It says, since the 2017 guidelines update related to TXA, what do we know about adoption and scale up in countries?
So this is Mariana. We are evaluating, and we are going to evaluate precisely this, the use of tranexamic acid, in our implementation research project, the eMotive, with the bundle. So tranexamic acid here is part of the bundle. And in addition, we are going to also look at the quality of the tranexamic acid being used in all the settings where the eMotive is conducted. So that's what I can say from my side. Over.
Great, thanks, Mariana. And just so you know, so the next session is actually a panel session where we do talk about the existing challenges and entrenched obstacles, and that's around guidelines and the dissemination and implementation of guidelines. And so looking at country experience, so maybe touching upon that in the upcoming panel. Great, thank you. Next question is from Anthony. It says, facilities use 600 and 800 micrograms for treatment of PPH. Can you please comment on the correct dose and route of administration?
Okay, so the dose we recommend is 600, 400 and 600. And in our new recommendations, we are recommending between 400 or 600 orally. This is at community-based.
Is that for prevention or treatment, though? I think you're speaking prevention, Mariana.
Yes, yes, you are right, Debbie. Thanks.
Yes.
So and just to confirm, for treatment?
Yes,
so
for treatment.
Yeah, for treatment is 600 micrograms. Fernando, can you help me here?
Sorry.
He's a medical doctor in charge of this.
Regarding, let's say, the correct, let's say, dose for treatment using misoprostol?
Yes.
Well, so, actually, this is a, well, this is a, let's say, this is a major question. Actually, we don't know right now what's the appropriate question either for, let's say, prevention or for treatments. And what happens, let's say, when you use this sequentially. So right now, I think that between, let's say, 600 and 800, let's say, is what is, let's say, is recommended. However, now, let's say, the current recommendations, the new updated ones, are not dealing with treatment of PPH and only as advanced misoprostol distribution during pregnancy as a strategy to, let's say, increase the use of misoprostol for PPH prevention. So actually, I cannot give you more details than the ones that are already in the WHO guidelines 2012, which definitely are that need to be, let's say, reviewed. Right now, let's say there is an upcoming systematic review, a Cochrane one, in which, let's say, there is an update of all the evidence regarding PPH medical treatments. So there we will have more evidence regarding, let's say that, and it should be forthcoming in the next couple of months, probably.
Great. Sherry, were you about to comment? Did you want to comment?
No, sorry, I think I just stepped on somebody's transmission.
Okay, thanks. And another question, so maybe two more. So Andre Lalonde, it says, if I can understand this correctly, about understanding the WHO recommendation on UBT, where WHO states that it can only be used where emergency surgery care is available. In a case where the referral center can be hours away, the use of UBT by trained personnel would be life-saving. Also consider the delays of the referral center, which could lead to maternal deaths. So why did WHO qualify that recommendation?
So when we make recommendations, we look mainly at the safety of the women. So in setting these preconditions, the panel that reviewed this recommendation made emphasis on minimizing the harm to the women, which could result from failure to or delay in implementing other temporizing or more invasive PPH treatment, or incorrect patient selection for the application of UBT, poor monitoring or redirection of resources away from other essential components of quality of PPH care. So there is not a lot of evidence, and that's why this recommendation is context specific, and whatever we do, it's going to be under research. So the GDG, when did this recommendation, agreed that there is need for additional rigorous research evidence, and that before getting these results, they cannot make this recommendation in a different way, that we need to follow these preconditions.
Just to expand a little bit on that, and let's say I perfectly understand, let's say, the frustration. Unfortunately, let's say the GDG considered that that definitely this kind of settings and this kind of problems that that Andre is mentioning are, let's say, definitely a research priority. But right now there is not enough evidence on whether using a UBT or not using, and just referring the woman with a, let's say, a garment is better. So we need that any use at the context, it would be good if, let's say, this can be, let's say, proposed in the context of, or answered in the context of some kind of rigorous research, definitely.
Great. And one final question for the panel, then we'll move on. When oxytocin, this is from Anonymous. When oxytocin is given IV, is it going to be mixed with saline or without, and what should be the duration?
I was waiting for the doctor to answer, but I can answer if he wants. So it's with
Please.
saline, and it has to be a slow infusion.
Oh, sorry. Yes, it's slow administration, less than 5 minutes. That's the issue. Can be again infusion or just administered with a syringe. But and we discussed this, let's say, during a lot of time trying to find the correct wording. And still we would like, let's say, definitely your reaction when you see this published. But right now the consensus was in administration less than 5 minutes. Again, using either syringe or infusion.
Great. So I think that's enough. We don't have any more time for the questions. Again, we'll answer the questions as they're in the box, and we'll get the answers out to you. Just want to extend a big thanks to the panel. Again, another excellent panel, and really appreciate your time and your expertise in sitting on this panel. So we'll move to the final session of the day, and I think this is, I think it